Hello, friends. So I'll be talking on this proning in ARDS. So this is a context setting for the journal review that's going to happen, where there'll be discussion on this trial that happened with regards to proning in ECMO. So I'm just going to give a brief overview on conceptual understanding of proning and the physiological advantage of proning and some sort of a hypothetical modeling that has explained the benefits of proning. And then we'll look into the evidence that has evolved in proning. So it's a good topic for all the trainees, DNB or DM students, because this can be definitely be asked as a question. And one needs to have a good clarity on the physiological understanding of proning. So wish to acknowledge my colleague, Dr. Pradeep, who helped me develop this content. So when we talk about proning, so we need to understand what really happens physiologically. So, for all the listeners, for all the trainees, the lung is modeled in a way where a lung is structured as a conical one, which is sitting in a cylindrical sort of a chest wall. So, there are these elastic forces that influence the recruitment and the functionality of the lungs against the rigid chest wall. So, that is the sort of conceptual understanding that one needs to have to understand how proning helps. So as I said, it's a conical. So lung is looked at as a conical structure. So when you look in the supine position in an isolated lung, so this is the normal lung. As you see, all the alveoli seem to be recruited and they're doing well. All these round ones are alveoli. So, and this is in ARDS. So this is a normal lung. So in ARDS, as you see, there will be some sort of a basal atelectasis and the consolidation that sets in. So there is some sort of a heterogeneity that happens. So we call it as a shape matching. So I just created a pictorial image for you to understand what shape matching is. Shape matching is the conical lung with its elastic properties um, matching to the rigid chest wall surrounding it in a diseased lung. So that is what we understand by shape matching. And this and the functionality of the lung is influenced even by the underlying diaphragm and the abdominal sort of a pressure that has a bearing on the diaphragm, which also has an influence on the lung function. So this is what we call as shape structuring or shape matching that happens when the lung gets diseased. And in addition to this, there are three components that trainees can sort of remember as to what affects the lung in ARDS. One is shape matching. Shape matching is, as I said, the conical sort of a lung within the rigid chest wall and the effect of diaphragm. The second one is the gravity. So the because the patient is lying down on the lying down, there is a gravity that has a bearing on the basal structure and that which accentuates or worsens the atelectasis process. Then the third aspect is the compression, because the heart itself has a compressive sort of an effect on the basal structure. So these are the three elements that all the trainees need to know. And these three have been derived from sort of a structural modeling or the hypothetical modeling that they have done. So shape matching is one, the gravity and the compressive forces. So these are the three things which leads to the perpetuating or worsening of the ARDS predominantly happening at the basal structure. So if you look at this ARDS lung compared to the normal lung, you see all these basal atelectasis or consolidation, which are not participating in the active ventilation process. So this is typically what happens in the supine position. So these images are in supine. So when you prone the patient, so this in normal lungs, as you see, even in normal lungs, you see there is a nice sort of a recruitment that happens in the dorsal aspect, and so is the ventral aspect. But there is no hyperdistension of the ventral aspect. And then here the shape rematching happens. And then the gravity also has an impact. And as you see, all the basal structures get opened up. And so there is sort of a participation of all the lung units from the dorsal area in the ventilatory function. And this progresses over the time. So this is what typically happens when you prone. So the basal structures get recruited and they participate in the alveolar ventilation. So this is pictorial representation of what happens in supine position and what happens in the prone position. And for all our trainees, just remember these three concepts as to what helps in proning. So you try to eliminate the gravity and then you try to eliminate the compressive forces. So compressive forces is, I'll just show you in the image. And the third one is the shape matching that happens. So again, a pictorial representation. So when someone is lying supine, the alveoli tends to get collapsed. And when you prone, as you see, the basal parts of the lungs get recruited, and there is non-collapse of the alveoli. And they re-emphasize this, there is no over-distension of the normal alveoli in the ventral aspect of the lung. That is also an advantage that happens in the prone ventilation. So as you see in supine position, you see the heart is sort of compressing. So this is a supine position. And if you put on the prone position, so you see the heart you tend to eliminate the compressive effect of the heart on the basal portion. So if you see here, heart is putting its compression, there is a compressive effect of the heart on the basal part of the lung. But here in the prone position, you're eliminating and the basal portions are sort of opened up. So this is what you typically see. So this is the compressive effect which you tend to eliminate in prone position. So gravity is something that has a bearing. The compressive effect is what they have a bearing, and there is a shape matching. These are the three components which have a influence, tremendous influence on improving the ventilation when you prone the patient. So this is our conceptual understanding. So this is another important aspect. The original hypothesis of ARDS was there is a ventilation perfusion mismatch. So here you have the basal parts which are atelectatic, which are consolidated, and our understanding is wherever there is atelectasis consolidation, there is a hyperperfusion. There is perfusion, but there is no ventilation happening. So there is a ventilation perfusion mismatch, and this was explained as a reason for hypoxemia that happens. And when you prone, and this gets better. So this was the original hypothesis, but now this concept has been changed to something called where they believe that predominantly the basal part of the lungs contribute to 75% of the ventilation, and the apical part, which we traditionally call as baby lungs, contribute only 25%. But when you prone, the reverse happens. So the basal portion contribute to 75% of the ventilation, and the apical part, which is anyway contributing to only 25%, is also ventilated. So this is the current hypothesis to try to explain how prone helps in improving the ventilation. Before it was touted as more of ventilation perfusion mismatch, but now the understanding is because the two-thirds of the ventilation is predominantly happens by the basal part of the lung, which forms the significant chunk of the lung functional units, are participating, that tends to improve your ventilation and oxygenation is our current understanding. And all these are hypothetical, all these are derived from the hypothetical modeling of the lungs in an experimental setup. So you can all take this with a pinch of salt, but this is our current understanding. So when you look at the supine, in supine, the ARDS lung, so this is the shape matching which I was telling. So you are looking at the lung as a conical structure. So this is just the image I've created to make your understanding simplify. Even in exams, they ask you can put this picture. So you are looking at lung as a conical structure within this cylindrical rigid chest wall. So this is the lung. So the basal part is the significant part which participates, and there are these elastic forces. So you are conceptually looking at the lung as an elastic structure within the rigid chest wall, and the shape matching happens even by the influence of diaphragmatic movement and the effect of abdomen on the diaphragm. So this is what we understand conceptually as a shape matching. So when you look at inner supine, so this in supine position, there are three components burdening the lung and affecting the oxygenation, which again I've been re-emphasizing is the gravity, shape matching, and superimposed pressure. When we talk about superimposed, it's the heart, which is applying more pressure on the basal aspects of the lung. So but proning, we are eliminating two components of this. So we are eliminating the gravity, we are eliminating the superimposed. Anyway, shape matching is an innate nature of the lung, which is happening with the compensatory effect of this elastic lung within the rigid chest wall and the influence of diaphragm also. All these are the three components which help in shape matching situation that tends to happen in ARDS. So this is our current understanding. So this image pretty much summarizes what shape matching is. You are envisaging or conceptualizing the presence of lung in a conical format with an elastic features in the rigid chest wall influenced by the movement of the diaphragm and the abdominal pressure. So that is what we understand by shape matching that tends to happen as a natural process of ARDS in a lung. So that is what the current understanding is. So that's about, so this is again the CT images to confirm how prone helps. So if you look at the CT, so this is a CT image of a patient where CT scan was done in supine position. And after 16 hours of prone ventilation, they have done an imaging, and you can see how nicely the basal structures are participating in the ventilation. So based on these, they have created this modeling, the functional modeling of the lungs, and determined that it is these three components: the gravity, the compressive forces, and shape matching is what determines the advantage or the benefit of proning. What we have understood. So this is a nice image which tells you that how the basal units are fully consolidated in supine, but once you prone, all these basal units have opened up and they're participating in the lung functions, which contribute to 75% of the ventilation. So this is what we understand by the prone. So now, since the talk is more on ECMO proning, so there are a lot of logistics involved when we prone. There are 8 steps that one needs to follow when someone is proning an ARDS patient. I'm sure most of the listeners would be doing proning routinely in their practice, but one needs to keep in mind these 8 steps, and possibly this can be incorporated as a protocol to all the nurses who needs to be sensitized to these 8 steps. The first step is pre-proning. One needs to have a checklist to determine as to whether all the tools that are needed for proning are in place, and all the uh, the pressure points, all this needs to be addressed. So for that, whatever is needed, so all those are in place. The second one is preparation. Preparation is checking all the lines, checking all the ventilatory connections, and having all the infusions ready, so on and so forth. So all these have to be kept ready. So preparation is the second step. Third step is called cocooning. Cocooning is where you get all the things that needs to be moved in the close proximity so that you can handle everything in one go whilst you are proning. So that is the cocooning. The fourth one, I'm sure most of you would know, is a horizontal move. So when you're proning, you have to take them through 3 steps. One is you move the patient to the one side of the bed. So that is a horizontal move. And all this happens with at least 4 to 5 personnel present, and the most important person would be the one who is at the head end, who is taking care of the airway. Because uh, just remember, this is an ARDS patient who is on a high support, who is on a high ventilator. So the someone who is managing the airway at the head end becomes terribly important. So the fourth one is the horizontal move. The fifth one is the lateral move. So which means you put the patient on one side, either left lateral or right lateral, whichever side you have moved, and then the final turn where you prone the patient. And the sixth one is swimmer's position, where you put the hand one in the front and one in the back. So this is what is recommended or suggested as the swimmer's position. And after one is done with all this positioning, again you need to look into the final checklist post proning. So in the checklist, you need to see if whether all the infusions are connected back, if patient is on some sort of a sedation, relaxant, vasopressor, so on and so forth. All these have to be ensured that they're all connected back, and the hemodynamic stability has to be ensured post proning. So these are some of the steps that are elucidated. So this can be kept as part of your protocol, at least to sensitize all the nurses on the various steps. So proning is not like ad hoc, random procedure. So one need to ensure that the whole safety is ensured by following these steps. So now the questions remain, does proning increase carbon dioxide? Because very often we see that after we prone, there will be some disturbance in the gas exchange, and sometimes we see carbon dioxide goes up. So what does that mean? So after proning, our expectation is carbon dioxide should come down. And if carbon dioxide comes down, oxygen improves. That is a favorable sign telling you that proning is really helping patient get better. And maybe it would help you to prognosticate that patient may do well with proning. But very often CO2 can go up. So why CO2 goes up? Because after proning, your chest wall compliance can come down, and if there is an unadjusted pressure controlled ventilation mode, there is reduction in the tidal volume, because in pressure control, pressure is guaranteed, tidal volume may come down, and that decreases the alveolar ventilation. In volume controlled ventilation, there may be increase in the dead space, and both of these reasons can increase the carbon dioxide. So one has to tweak with the ventilator parameters and see how best one can avoid getting the CO2s to go up. So RV dysfunction. Does proning have a bearing on RV dysfunction? So we do understand this is something I always emphasize in ARDS. One needs to bear in mind in severe ARDS, RV dysfunction occurs in significant proportion of patients. It is shown that RV dysfunction occurs in 30 to 56% of the patients with severe ARDS, and this has a direct bearing on increasing the 28-day mortality. And the mechanisms why RV dysfunction happens is because there is hypoxemic or hypercapnic pulmonary vasoconstriction that happens, and there can be microthrombi within the alveolar capillary membranes, and there is increase in the dead space. And we did speak in the previous slide as to why dead space increases in unadjusted volume control ventilation. Sometimes the dead space can increase in prone ventilation. All this can lead to RV dysfunction. And there are predictors of RV dysfunction, especially in severe ARDS. PaO2 by FiO2 is less than 150, and CO2 has an important bearing. That's why we emphasize now on CO2 being a poor prognostic marker, and even we have discussed about how CO2 is now become a criteria for someone who should go on ECMO. So we gone are the days where we accept permissive hypercapnia and allow patient to have chronic hypercapnia. If carbon dioxide is not coming down, it's very likely that proning is not helping him, and maybe you have to think of an alternate strategy, which is ECMO. So CO2 more than 48 can cause RV dysfunction, and driving pressures if they are perennially more than 18 centimeters. So if patient has any two or more of these, PF ratio less than 150, CO2 consistently more than 48, driving pressure more than 18, they are at a risk of developing RV dysfunction. Does proning help in RV dysfunction? Proning does help in offloading RV, and there is a study for this. So this is a study which is by the French group that came in 2007. So prone positioning unloads the right ventricle in severe ARDS. So this study was done in 42 patients, where patients were prone for 18 hours. And out of this, 50% of the patients, 21% of the patients had normalization of the RV, where it was dysfunctional at the outset. And there was improvement in the cardiac index, and there was reduction in the heart rate in 50% of the, it means proning did improve the RV status in 50% of the patients. So even if this happens, then you know that proning is helping them. Even if this doesn't happen, then obviously you have to think of ECMO if proning is failing. So does prone position alter hemodynamics? So very often I see that we say patient is hypotensive, that's why we've not proned. So, and that can be a common reason as to why we don't prone, but it is very clearly shown that should not be a limiting factor for proning, because MAP of less than 65 should not be a limitation. Why we say that? Because when you look at PROSEVA trial, which is a positive trial which I'll talk about, which showed significant mortality benefit, 73%, 70 to 73% of the patients were hypotensive needing vasopressor. So in PROSEVA trial, 72% of them were on vasopressors, which means to say that should not be a limiting factor for proning. So these are important message that came from this trial. And in PROSEVA trial, it was also shown these patients who were on vasopressors. In fact, the cardiac arrest was less, 6.8% versus non-prone patients, which means to say that proning is beneficial and it does not lead to hemodynamic instability or cardiac arrest, because cardiac arrest in fact was less in this PROSEVA trial. And even in PROSEVA trial, it was shown that the organ dysfunction, extra pulmonary organ dysfunction free days was higher, which is good, which means secondary organ dysfunctions also did not happen in prone patients, which means because many a times we may say patient has an AKI, that's why we want prone. In fact, the organ dysfunction was less in prone patients. So that's what was shown in PROSEVA trial. So, so what about the evidence for proning in ARDS? So the evidence for proning has been happening over last 30 years. So from 3 decades, the evidence is building up. So just take you through the four important studies which has looked into proning. And all the earlier studies in last 20 years were negative. It was only the PROSEVA trial which became positive. So the first study came way back in 1996 to 99 by Gattinoni from the Italian group. It was a big study, 304 patients. And as you see, they proned only for 7 hours for 5 days. And here they looked at mortality benefit. There was no mortality benefit. That's when we knew that gas exchange improves, but there was no mortality benefit. But please mind you that at this in 1996 to 99, protective lung ventilation was not used. Then the Gurin et al. So this the PROSEVA trial was done by Gurin et al. Later on, but the initial trial by Gurin et al. In 1998, here they did not use protective lung ventilation. They used prone for 9 hours for 4 days, and they followed up the patient for 90 days. And it was the biggest study. 802 patients were recruited, and there were severe ARDS. So when they looked at mortality, there was no benefit between supine and prone. As you see, it was not statistically significant. So it's the same Gurin et al. Who did the Proseva trial in 2013, after around 10 years. So 2006, the Spanish group Mancebo et al. They did a study. Here they prone for a much longer time, 17 hours, and the number of patients are 142 for 10 days. Here they use tidal volume less than 10 ml. Again, here they did not show any mortality benefit. So this was the prevailing evidence. And after that, there was this another study by Tepponi et al. From Italian group. Here again, they prone 18 hours per day for 8 days. Here again, they used little bit of protective lung ventilation, tidal volume less than 10 ml. Again, here they did not show mortality. So this was the evidence we had over last 25 years about the proning. So where none of them showed mortality benefit. Then came this Proseva trial. So this study, again, as you see, was by Gurin et al., who did the earlier study around 10 years back, came in NEJM. Here they took patients with ARDS less than 36 hours, intubated, mechanically ventilated, and prone for 16 hours. They took severe ARDS, which they defined as FiO2 TF ratio less than 150, on FiO2 more than 60% with PEEP of more than 5 and tidal volume 6 ml per kg. So what this was a hugely positive study compared to all these previous four negative studies. So they had 460. As you see, the previous urine study was done in 800 patients. Here it was 466 patients. 237 were in proning, 229 were no proning. Ventilatory free days, which is good. So the reduced duration of mechanical ventilation was found in this proning and as opposed to no. So ventilatory free days was higher, which is good in proning. And the extubation, more number of patients were extubated in proning group, 81% as compared to 65%. Again, statistically significant. And the striking thing about this Proseva was there was a mortality benefit, which none of these four previous studies showed. 28-day mortality was 16% compared to 33% in no proning. And tracheostomy was little less, but it did not attain statistical. So this was the compelling evidence to say proning helps. So possibly for all the audience, one could reconcile as to why there was so much of mortality benefit because they all the advances that happened in ARDS with protective lung ventilation. Because if you see the previous studies, they used tidal volume less than 10. Now we are talking about less than 8, less than 6. We talk about 6 to 8. And then we have understood the whole concept of driving pressure. We have understood the concept of PEEP optimization. Possibly all these principles were applied along with proning. So it's not only the proning which has made a tremendous difference. So hugely positive, and then now we all understand this has become a standard of care. After this, there was a meta-analysis that came from the Canadian group, where in patients with PaO FI to less than 100, proning significantly reduced mortality. So this is the current evidence we have with regards to proning. So since the talk is on little logistics, so there are certain contraindications. There are around 7 contraindications, especially if someone has a TBI with high ICP. TBI per se may not, but if they have high ICP or if they have active GI bleed, hemoptysis, hematemesis, or cervical spine instability, and post-operative patients can be related, especially chest surgery. If someone has had a CABG, post-CABG or a chest surgery, that can be a contraindication. Or someone is very hemodynamically unstable with arrhythmias or chest injuries, chest trauma. And here, although I said hemodynamic instability map less than 65, it's a relative contraindication. As we said, in Proseva study, it was shown 72% of them needed vasopressors. It should not be when I say hemodynamic instability, it's an ongoing hemodynamic instability where we have not attained control over hemodynamics. That may be a contraindication for proning. Ongoing hemodynamic instability where we have not been able to achieve stability with vasopressors, that may be the contraindication. So with regards to logistic problems, yes, there are logistic problems with proning because you need at least 4 to 5 nurses and you need to have all these cushions to protect the pressure points and you need to ensure that all the pressure points are taken with these cushions. And there are certain problems that can arise with proning. There can be a lot of conjunctival edema, suffusion, and there can be copious secretions that can come out. And if we do not take care of all those steps, 8 steps of proning, so there can be dislodgement of certain CVC catheters or arterial lines. There can be displacement of the ET tubes or migration of the ET tubes. There can be migration of the Rayleigh tube, so on and so forth. These are some of the complications that we do see in proning, and these needs to be looked at. And sometimes hypoxemia can worsen, and we know proning can interfere with the chest wall complaints. So chest wall complaints can come down, and that can increase the dead space in volume controlled, and it can reduce alveolar ventilation pressure control, leading to increased carbon dioxide. So all these can be the problems with proning. And one needs to use neuromuscular blockers, especially for someone who is prone. So we cannot just keep them sedated. So they have to be relaxed. That can be a problem. And if they have arrhythmias of some nature, so it is sometimes difficult to manage them if they have a VT or so on and so forth. So these are some of the logistic problems with proning. So that's about in brief about the overview on proning. So summarily for all the trainings, as I said, we based on so there is a hypothetical lung modeling which tells us there is beneficial effects of proning. And when we talk about hypothetical lung modeling, they look at lung as a conical structure within the cylindrical chest wall, which is rigid. And and there is an effect of diaphragmatic also on the shape rematching. So there are three components one needs to remember how proning helps. Shape rematching is something that happens naturally in ARDS patient. There is a compressive forces by the heart in the supine positions which you tend to eliminate in the in the prone position. So and prone position significantly mitigates your RV dysfunction. So that we have seen from the study. And there is no hemodynamic worsening, and this was shown in the Proceva trial because the number of cardiac arrests were less in prone position as opposed to the supine position. And earlier three studies or four studies in last 20 years did not show any significant benefit with regards to proning, but the Proceva trial and the meta-analysis show significant mortality benefits. So as I've already mentioned, the benefits was due to proning and all the advances that have happened in our understanding of ARDS with low tidal volume, PEEP optimization, and driving pressure. So the logistic problems do remain. So one needs to take care of all the checklists and the steps for proning, and one needs to be sensitive and be cautious about all the logistic of removal of CVC lines, arterial lines, displacement of ET tubes, migrations of the Rayleigh tubes, so on and so forth in back of mind whilst you are addressing this proning situation. So that's a brief overview. So thank you one and all. So I request all our listeners to present their valuable work to Journal of Acute Care. So you can visit my website www.drsalipagappa.com to read her lecture. So thank you one and all.